Hey everyone, welcome to the Ovation Show, where we are discussing the healthcare crisis in America. And we're bringing partners, colleagues, clients, and business owners together to discuss solutions and innovations that bring a higher quality of care to employees while reducing their out-of-pocket costs. But we're also reducing the employer costs and giving them more transparency and control. And we are live today in the Work Innovators studio, where Work Innovators is amplifying the voice of business here at the VentureX in Castle Hills in the Realm. Today, we're going to get back into pharmacy and PBM and pharmacy management. And I'm really excited to have a good friend and my guest from Virginia, Renzo Luzzatti. He's founder and president of USRX Care. Welcome, Lorenzo.
Thank you very much. It's a pleasure to be here.
So let's just kind of talk about it. What is USRX Care?
Sure. So USRX Care, we play in the pharmacy benefit management space. But we came into the PBM space from a different place. We started on the health plan side of managed care. If you think of director of pharmacy at Humana or Blue Cross Blue Shield or Centene, managing Medicare, Medicaid, and commercial lives, upwards of 2 million lives. That's where we started. So a true risk management environment. If you're a health plan, you own your own claims. They're your expenses, right? You can't take them and put them on an invoice and send them to somebody else at the end of the month to pay. When you're operating in that environment, you tend to look at things very differently than the traditional PBM model. And we realized in 2007, after spending a couple of decades on the health plan side, that type of fiduciary, rigorous, clinically deep management of pharmacy risk just didn't exist for self-funded employers. So we started the company USRX Care in 2007 to bring all of those learnings and skills and successes that we had with health plans to the self-funded employer marketplace.
We talk about successes, and I know recently you just you were nominated for last year a pretty big award with it was a National Alliance of Healthcare Purchasers Coalition. And tell me a little bit about that.
Yeah, thank you for mentioning that.
It's pretty. I mean, it's a pretty big.
It's a big deal. So the National Alliance of Healthcare Purchaser Coalitions is kind of the umbrella organization to the regional business groups on health. So here in Dallas-Fort Worth, there's the Dallas-Fort Worth Business Group on Health. There's a similar one in Houston. There's one in Pacific Northwest and Philadelphia. There's about 40 some odd of these regional business groups on health. And the parent organization is the National Alliance. So I've been very involved in that organization. I'm on a committee that is involved in kind of strategizing on how best to manage and mitigate high cost claims. But they asked us to submit as a nominee for their Innovator Award last year. And we were nominated one of 6 finalists out of hundreds of applications. We didn't win. Cigna and Kaiser won. But just being recognized, from a national organization, all of their member organizations touch about 45 million Americans that are insured through employer self-funded plans. So we were pretty pleased to be recognized for our innovation in fiduciary pharmacy benefit management.
Well, yeah, it's pretty impressive when you look at who you were in that top. You talk about those 6 people. I mean, It was Kaiser Permanente, Cigna, Aetna. I forget who the other ones were, but I mean, it was impressive. It's an impressive list, and to be in that top 6, congratulations on that.
No, thank you very much. It was it's validation. I mean, we've been doing this for quite a while, and we've had a lot of success. But it's really nice to be to get that recognition from a national organization such as that.
So, going back, looking at pharmacy benefit PBM, pharmacy benefit managers, I'm not going to go into what that is. We're assuming most people watching right now are in self-funded. It's an area that they're looking at. But one of the things you mentioned in the last couple of days when we were talking with clients and traveling and doing things, you said we're really not a PBM. We're more of a PRM, more of a pharmacy risk manager.
Right.
So what do you see as the difference in those?
Yeah, so we refer to ourselves as being in the pharmacy risk management business, in part to kind of differentiate ourselves, as you said, from the traditional pharmacy benefit manager. Again, because of our heritage coming from the health plan side of managed care, where we were managing true pharmacy risk, you look at things very differently. Your formularies can look different. Your treatment guidelines, we think, are a little bit more rigorous. Things that you would do if you're at risk permeate everything that we do as an organization for our self-funded clients. We also take fiduciary compliance very seriously. If you're operating as a risk manager in a health plan, there's no conflicts of interest within your health plan, right? You're just managing your risk. Unfortunately, in the PBM industry, there's a lot of conflicts of interest that have been that has kind of filtered in over time. We take the definition of a fiduciary right out of ERISA, and there are 3 things. Number 1 is no conflicts of interest. Number two is only looking out for the best interests of the client and the plan participant. And number three is all utilization and financial information has to be in full view. So we put that right in our contract. And what it means is that we are on the same side of the table as our client. Many clients that come to us feel that they're in kind of an adversarial role with their PBM, and it doesn't need to be. And so that's just part of who we are, and it is a big differentiator. And it allows us to focus on managing pharmacy risk, as opposed to some of the things that occur in the PBM space that we think maybe are a little dated and can be improved.
Well, I think, you really hit on it, and we'll actually get a little ahead where I wanted to go later on. Talk about the fiduciary side and everyone having that responsibility of the client, being on the same side of the table, which is what we do when we're dealing with clients on the benefit side. You're fiduciary for the plan. When there was three big PBMs, it was Optum, CVS Caremark, and Express Scripts, and they're not fiduciary. When we look at their contracts, I love bringing this up because this is a contract torn apart. I got to share this. I'm going
to let you talk about.
I'm going to talk about this because we tore apart this contract from a big PBM, and there's pages and pages of things that are slanted or in the favor of the PBM and not the client. And so, you can't say you're a fiduciary when all these things in here benefit you or them as a PBM. And you mentioned one thing, that's why I went right to this. You mentioned, you're governed by ERISA.
Yeah.
And on the front page of this contract, it says that the PBM, this pharmacy benefit management plan, is governed by ERISA. But if it's governed by ERISA, there's another paragraph in it that says that they are not fiduciary. Mm-hmm. So I don't, that doesn't make sense to me. If I'm governed by ERISA, but I'm not a fiduciary. So what does it mean to not be a fiduciary? When they put this in a contract, what does it mean to not be a fiduciary?
You're putting me on the spot.
I have to on that one, But just so everyone understands the difference.
Yeah. So, if you look at that first definition of being fiduciary or a role of being a fiduciary is no conflicts of interest. But then you look at the traditional PBM model, they own the mail order pharmacy, right? So there's an inherent profit center that is a potential conflict to the role of managing the pharmacy risk. They own the specialty pharmacy. In some cases, the PBMs own the retail pharmacies, right? We've seen cases where 80-90% of the benefit spend is going to pharmacies owned by the PBM. Right. You don't have to think too hard to say, well, that may be a bit of a conflict of interest because there's a competing profit center within the PBM that runs counter to the ultimate mission or expectation that they're there to manage cost. So we kind of turn all of that on its head, if you will. And again, we came out of the health plan space. There's no conflicts of interest when you're managing your own health plan, and we just took that same model and bring it to self-funded. So for us, it was easy to put the language in the contract that we're fiduciary compliant because we are.
So when we look at these contracts, and Dave Contorno, when he was on, he said, hey, you got the three big PBMs. There's 72 ways that they profit off of a client, and we found a lot of them in that contract, but they're profiting in all these different ways. They're directing their mail order. They're directing them, CVS Caremark, but they have their own pharmacies. They're directing people there, making you get certain drugs from there. And I get that. That's where they're profiting. But you're not doing any of that as a fiduciary PBM. So how do you, let's get right. How do you get paid? How do you make money if you're not getting spread pricing, rebates, all these other things?
Yeah, so we're not in the business of marking up drugs to our client, right? Or selling drugs at a profit. At the end of the day, we get paid a flat administrative fee for our services. And our goal really at the end of the day is twofold. We want to make sure that we're optimizing the care for the member, we're getting the drugs right. And the second is that we're buying them at the lowest available cost, right? So those are the two areas that we focus on. And those are really the two areas that have the greatest impact on the member experience, but also on cost, right? So by stripping away all the potential conflicts of interest and all those potential profit centers, it really allows us to focus on the things that matter. Right. And, the proof is in the pudding. We've got lots of clients, including some of yours that have saved, 60, 70, 80% in the first year.
80%, that was yesterday. That was impressive because when we look at our client, multiple clients that we have with you, and, we go in and do pharmacy consulting or even our self-funded clients, and we say, we know we'll guarantee 30, 40% savings on pharmacy. But the clients we're looking at, I think the lowest one was 53. We had a 60, 67, something like that. And then, of course, the other one was 73% the first year, and now they're even 83% when we started. So, that's amazing what we're doing.
There's that much waste in the system, unfortunately. And it's interesting. I mean, we've been talking about this and working in self-funded since 2007. But I would say it's just been in the last 5-6 years, maybe, that most employers in the country are finally realizing that the old way is probably not the best way going forward, right? So they're asking a lot of the right questions. They're digging into the contracts like you're talking about and say, wait a minute, this doesn't sound right. This doesn't sound like it's in my best interest. I think the biggest challenge for employers are that there's not enough folks like us out there, right? And so a lot of employers, they see the issues, but they don't know where to turn, right? Which is why I'm really pleased to be part of your show, because this helps get the word out.
The pharmacy side we've learned is it's just this low-hanging fruit for a client, for a prospect, or for a company. You go in and you say, well, we can save you money in the medical management and on your claims, but it may take a lot of unbundling and then rebuilding the plan and a lot of pieces that we have to manage and build out and educate employees. Pharmacy is a very easy way. In fact, when we're doing pharmacy consulting, I tell them, take your pharmacy spend and just what's 40% of that. So if I can put 40% of that back in your pocket without sacrificing any care with any prescription drugs, what would that do for you? And that's the process we go through, because it's such an easy way for employers to have an impact immediately. And, they'll start seeing impacts almost immediately on that.
It's true. No, it's, pharma, one of the advantages of pharmacy is 99+% of it is immediate and it's electronic in terms of the dispensing and the interaction between us and the pharmacies. And even interaction with the doctor's offices, a lot of it is electronic now. And there are so many options available in pretty much every therapeutic category, and they can't all be right. It's the same on the medical side. I know we've been talking about that for years, but you're absolutely right on the pharmacy side. It's a lot less complicated, and there's just so much waste. Yep.
Well, I know that's what I wrote in the book, Life and Death Decisions of the C-Suite. There's chapter 18. I wrote about life and death at the drugstore and employees being able to get their drugs and controlling the costs and how it benefits the bottom line. One of the things I didn't talk about, which will probably be in the next book or next chapter I write or the next white paper I do, and something that we talked a lot about yesterday, and you just mentioned it, but in that process of clinical rigor.
Yes.
So tell me, because you bring that up, I don't hear that a lot. So talk about clinical rigor.
Yeah. So, at our roots, USRX Care is a clinical pharmacy organization. We happen to work in the pharmacy benefit management space, and we have, all of the attributes that you would want for managing pharmacy benefit. But at our roots, we really are clinical pharmacists. We've got a large team of clinicians, MDs, pharmacists, techs that are reviewing the literature all year long. And again, looking at it from the fiduciary perspective, right? We're not looking so when we build our formulary, for example, we're not looking to maximize rebates, which has been the mantra of the past. More rebates, more rebates, more rebates. The problem with rebates are you have to spend $100 to get $20 back. Years ago, I was at a conference and I was talking to a CEO at another PBM. They've since sold. They're no longer. But he referred to rebates as fool's gold. And I thought, wow, that is a really good way to put it, right? Because it seems so good and shiny, but at the end of the day, if you're optimizing rebates, you have to drive up costs to get those rebates back. It doesn't make any sense, right? So coming back to the clinical, what we've seen, unfortunately, in the industry is the influence of drug manufacturers on PBMs has been substantial. And I used to work at a drug manufacturer, so I get it. But we've seen, formularies get altered, treatment guidelines get diluted. They're not necessarily following best practices. So one area that we've made a huge dent is particularly on specialty pharmacy. We see, unfortunately, a rubber stamp in many PBMs, right? Because there's an incentive to get it to the pharmacy as quickly as possible to dispense, because you can make a lot of money off the specialty. We don't do that. We don't own a specialty pharmacy. We don't own a pharmacy. So our goal is to get the drug right. If I can use an analogy, we were talking about this yesterday when we were meeting with some of your groups. The way I look at the prior authorization function is kind of like buying a car. So I don't know when the last time you were on a showroom floor, but you're on the showroom floor and you're looking at, what color do I want? Do I want the sedan? Do I want the hatchback? What kind of tires? What kind of stereo system? All of that stuff. You're trying to pick the right car for yourself. That's what we do in the prior authorization function. we are wanting to make the best decision for that individual, for their care, where they are at in their course of disease, what drugs they've tried and failed before. It really is an art more than it is a science, but you also need to know at a deep level what's appropriate on label, off label, and there's a lot of complexities, right? So we dig in really deep, and at the end of the day, though, if there's 3 drugs that all do the same thing, and they're all going to have the same outcome on a patient, of course we'll look at the ones that are lower cost, right? Why wouldn't you? That unfortunately doesn't always happen, we see, within the traditional PBM space, which again fosters some of the waste. And unfortunately, as an employer, they're relying on their pharmacy benefit manager to make all those decisions and do it with the client's best interest at heart. And unfortunately, we don't always see that.
I think that kind of goes along with what we've always talked about in the Next Gen Mastermind, and even when like Deb Alt says it, getting the right care at the right price at the right time. And that goes into, let's make sure it's the right drug they're getting. Are they taking the right one? And then, of course, getting the right price. And that kind of leads into, you mentioned sourcing the drug at the lowest possible cost. And using your analogy with a car, look at now, I go into this dealership, I find the perfect car, and we know that it's this drug, it's this car that I want. But I look at it, it says MSRP on the window.
Yeah.
And, in the past, you say, well, I don't want to pay MSRP. I want to pay the lowest possible invoice cost, whatever.
Mm-hmm.
And you negotiate to hopefully get that lowest cost. Now, we're even seeing in the car industry now where MSRP, people are paying 10, 20% over MSRP. So the car analogy really fits in the pricing of drugs now.
It's crazy.
But how do you get that lowest cost? So what are some of the things that you do on your end to benefit the client?
Yeah, so that's kind of the second. If I think of, let's talk about specialty drugs. They have to go through a prior authorization process, review process. We want to make sure we get the drug right. But if you're back on that showroom floor buying the car, once you picked out your car, what happens? You got to talk to the person in the financing department. How am I going to pay for this shiny new vehicle, right? That's the second piece that we've included in our process. Once a drug is approved, then we look to see where can we get that drug at the lowest available price. We certainly leverage every penny that's available in manufacturer programs, whether it's copay assistance, and maybe we can, for those that may not be familiar, we can, flesh that out a little bit. But there's coupon programs, copay programs, and also needs-based programs where individuals can get their medications for free. So that's the first rung that we would focus on to get discounts, because that's really low-hanging fruit. And then there's a number of other different options that we can look at, including leveraging a network of pharmacies, particularly on specialty. Typically, when you're working with a PBM, you have to get your specialty drug from their specialty pharmacy. That's part of the contract, right? That doesn't mean that that pharmacy is necessarily going to always be the cheapest. They can't be the cheapest all the time. So we shop. We have a network of pharmacies, and whoever has the best rate for a particular drug gets the business. Right? Why wouldn't you?
Right.
Just like you're buying your groceries or whatever, you want to get it at the right price. So all of that is part and parcel of the flexibility that we have when you take all the shackles off that are inherent in not being fiduciary compliant.
Okay, great. So I want to take a quick break for a moment. When we come back, I'm going to talk to Renzo more about the things they're doing in innovation and how they're helping employees and employers get their costs and find their drugs at the lowest cost. Be right back.
As business leaders, we all know that healthcare is expensive. In fact, it's one of the top 5 expenses in most companies. The decisions you make or don't make in your healthcare plan can have financial repercussions down the road. But not all is lost. There are ways to take charge and get your employees the best possible care, all while reducing overall costs for us as employers and employees too. Get your copy of Life and Death Decisions in the C-Suite, where Dan Labroad and his colleagues pull back the curtain and address how the private healthcare system and health insurance industry have plagued businesses for decades. What you'll discover will empower you to take back control over your health insurance costs that could mean massive savings for your company while giving your employees better quality healthcare. Get your free copy now at the link below or using the QR code provided.
Welcome back, everyone. We are live in the studio today with Renzo Luzzatti, the president and founder of USRX Care, one of our great strategic partners. And so, Renzo, let's just continue where we were. We talk about lowest cost, clinical rigor, a lot of things you're doing, but you were nominated for that award for innovation. And so tell me about the innovative things you're doing that basically got you that nomination.
Yeah, so the fiduciary compliance is part of it, and that was recognized because we're an anomaly in the industry, right? There's a couple of other things. As I mentioned, I've been very involved in a high-cost claimant committee at the National Alliance, and a lot of the things that they're now promoting are things that we've been doing for a number of years and have been successul in implementing in your own clients. So congratulations to you for being an innovator.
You made me look good.
And jumping on early. But when it comes to high cost claims, that's kind of the big fear factor right now for self-funded, right? Because one individual employer can struggle, frankly, to if they have a $2 million claim, for example. What do? It's going to hit stop loss in the first year, and you're going to own that claim the second year. For an individual employer, it's tough, right? So what do? We found that there's three main strategies that we have found to be valuable to mitigate and avoid high cost claims. Number one, we talked about a little bit, and that is deconflicting the clinical decision making, right? Taking the profit incentives away from the decisions that you make clinically, right? Because that can dilute and distort your decisions if there's a profit incentive to approve, for example, a drug that may not necessarily be appropriate or needed. Second is to dig into the medical side of RX. What do I mean by that? When you look at specialty pharmacy spend, 40% goes through the medical benefit, not through the pharmacy benefit. And we find that a lot of organizations are not looking necessarily under the cover at what's going on over there. And unfortunately, what's going on over there are egregious, we think, charges that come through from practices that are administering drugs and submitting charges and then getting paid a percentage of charge through the TPA, if that makes sense. We've seen markups of 500% above that list price,
Wow.
that sticker price, 700%. And one of the things we were talking about yesterday, Nurse Deb and AIM,
Yep.
We co-manage a lot of groups. She's so well known that I've started to say, if you don't really understand, USRX care, we are to pharmacy benefits as Nurse Deb is to medical benefits, right? Because we're doing the same thing. We're getting the drug right, and we're making sure that it's sourced appropriately. Everything we talked about in terms of manufacturer programs and whatnot, she, fully on board there, and also in her realm, managing the site of care, right? Moving it from the hospital to the home, for example. One of the areas that we've collaborated with her team is if there's a doctor's office that's looking to buy a bill at an egregious rate, they'll let us know, and we'll dispense the medication through a pharmacy and send it to that clinic, or sometimes to the patient to bring to the clinic to be administered. In the industry, it's known as brown bagging or white bagging. Brown bagging, sending it to the patient to bring in; white bagging, sending it to a clinic. We have a kind of a landmark case study that I'd love to share with you.
Yeah,
if that's
please
okay.
do.
There was a TPA up in New Jersey that had wasn't Nurse Deb in this case, and a medical management firm that had approved 2 chemotherapy agents. They were being administered from a well-known cancer facility up in Pennsylvania because the family lived right across the border. And they charged $248,000 for 2 chemotherapy agents per course of treatment. The first payment went through. And then someone at the TPA said, well, did anybody ask USRX Care what they would do? So they gave us a call. And we're now shipping those agents from a pharmacy for $15,000.
Wow.
So the difference between $248,000 down to $15,000, the patient's getting the same drug. So that's something that we work together collaboratively with Nurse Deb and her team. They'll give us a ring. We'll put the overrides in our system, and we'll dispense from whatever pharmacy is the lowest cost. So it's a big cost saver, for the client, and we're happy to do it.
Well, I think that's the whole realm of the next gen benefits model that we embrace and that you embrace, and Nurse Deb is making sure that you're getting the same care or better, but you're lowering the cost,
Right.
and you're not. I mean, if it's a big deal to the employers when you say, yeah, we're going to save you $248,000, $230,000 twice.
Right. Well, multiple times. Yeah, because it was per course of treatment there. So you're talking, they could have spent a few $1 million, and now they may not even spend $100,000.
There was a case we had not long ago, I think it was about a year ago, and that brown bagging idea, it came up, and we had, the TPA had called us and working with the pharmacy, and that was, they were going to administer a drug in the hospital, but there was a pharmacy right next door.
Mm-hmm.
And we found out that the cost of the employee was going to be very high too.
Right.
And they were worried about that. And then we got the notice to, hey, we can get the pharmacy next door, pick it up and bring it back to the hospital, and they'll administer it. It had to be administered by a doctor, but it didn't matter where you got it.
Right. Yeah, at the end of the day, in some ways, I feel like we're at war because the number of specialty drugs that are coming to market and the price points are just astronomical. And again, from an individual employer perspective, it's unsustainable, right? So from our perspective, anything that we can do to get the drug, as you mentioned, 'cause a lot of these strategies like the brown bagging, we're not changing the drug. In that particular case, those two chemotherapy agents were exactly the right choice for that patient because we did take a look at that also. It was a matter of just buying better, right? And you need to have the right partners at the table that are willing to do that, right? And so I'm glad Nurse Deb came up because we're a big fan of hers.
Yeah, there's a lot of great partners. I mean, you and then Nurse Deb, and then we talk a lot about, of course, specialty medications, and that being the biggest portion of pharmacy spend typically is 5% of the employees taking these high dollar specialty meds like Humira, and being able to eliminate those through different programs such as copay assistance, manufacturer coupons, manufacturer assistance programs,
charities,
international pharmacy. You've got a really great partnership with Gary Becker at Script Sourcing, and so do we. They've saved our clients, hundreds of thousands of dollars, just like you have. So looking at case studies, you mentioned the one case study, but let's talk a little bit about case studies, because I know my own experience working with my pharmacy consulting clients, my employee benefit clients. Again, we always say, implement what we're telling you, put in a fiduciary PBM, analyze your contract. Let me show you all the ways you're being screwed. And I won't put it lightly, because it is. I see these contracts that drive me insane. But let's look at all of this, put these in, and I'll guarantee 40% return. I mean, you're going to save 40% without sacrificing it. And so my clients have seen, 50% plus, all the way up to right now, 83% savings. But talk some other case studies that you usually refer to.
Yeah, we were actually called into a union group in Hawaii. This was about 4 years ago, and they had 3 hemophiliac cases in their population, 2 kids in one household and another kid in another household. And they were spending $3.5 million a year on those hemophilia agents. And so we went in and looked, and we thought, well, maybe it could be a manufacturer program or not. It turned out that both families had a secondary payer that wasn't contributing anything to the cost of those medications. So we made some changes in the benefit to have a more equitable share, if you will, between the union and the secondary payer. And we were able to do that, and they are saving now. I think they've saved a total of over $10 million just on those 3 agents. That's game changing for a union. I mean, it was just crippling their trust fund, right? And so yeah, those sort of things make us. I mean, that's why we're in the business, because at the end of the day, we're making a big difference for the client. Another area that we've seen a lot of opportunity is we find that in some PBM contracts, the way the specialty discounts are set, it's an aggregate, it's a combined on brand and generic, AWP minus 22, 25, whatever it may be. But often you can get generic specialty drugs a lot cheaper at a retail pharmacy than you can get from the specialty pharmacy. So we've taken over some groups, and I won't mention the PBM, where they were spending $80,000, $90,000, $100,000 a year on generic specialty drugs that we were able to source by moving them to the local retail pharmacy, where the individual can just go to their local community pharmacy, and we brought the cost down to under $1,000 for each of those drugs. So $80,000 versus $1,000 just by changing the pharmacy.
It's crazy. So you mentioned like local pharmacies, and I know one thing that we use and we have our clients use a lot on your website, you've got the lowest cost pharmacy search tool. Yeah. Talk a little bit about that, because I think that's an innovation that we don't see a lot.
Yeah, we're complimented. And, when we put that up there, and, at open enrollment, we send lists of to every group of the lowest cost pharmacies in the area. I'm sure some of that stuff just ends up in a drawer and people forget about it when they need it, right? So we put it up on our website. You can put in a zip code, and it'll show the lowest cost pharmacies in that zip code. And to be quite honest, I wasn't sure. I mean, we were seeing some traffic, but I wasn't sure how much it was being used or folks were actually using it until there was a change in the browser that disabled that function for a day. Right. And, we got it fixed in a day. We had to change the code, but it wasn't working for a day. And you would think that the world had come to an end. The phones lit up, I'm trying to look up my so people are actually using it, which, shows that, if you give people the tools to shop, they'll use them. And the cost difference could be dramatic. The bigger box stores are always more expensive. They know they have to be in the network, and they drive a hard bargain. Often where you get your best deal is in the grocery store. So we tell folks, you got to buy your groceries anyway. Yep. Why don't you just get your medications at the grocery store? You save money. And it can be significant, particularly on generic medications. So yeah, we encourage that. We also have a price lookup tool that they can go into that actually allows an individual to price out their drug at that point in time in their benefit. So that they had a deductible, they'll see how much goes towards the deductible. They can see the actual cost of the drug. So they can shop the pharmacies in their local area and find the one that works best for their particular medications at that time.
I think that tool makes sense because we looked at examples yesterday, but if my copay is 10, 15, or 20 on a generic, most generics fall underneath that.
Right.
So you're paying whatever the price is.
Right.
So, and we've seen in your tool, we've seen it on GoodRx, it varies significantly between different pharmacies. One can be $23 and one can be $4.
Right.
And so if I'm paying 100% of that cost, I want to get the cheapest one available and go to the cheapest pharmacy.
Absolutely. And if you're paying that $23 and it's a chronic med, you're paying that every month.
Yep.
So it adds up fast. And if you're on 2-3 meds, it makes a huge, huge difference. So we get a lot of compliments. To your point, these sorts of tools are not ubiquitous out there. And when we're able to educate folks and show them that they were spending hundreds of dollars and now they can spend tens of dollars on their medications, they're thankful, right? Some folks actually are a little angry that they didn't know before. How come? You mean I've been spending all this money and I didn't have to? Well, yeah. We're glad that we're here and we're glad that we were able to educate you. So it's a really good feeling.
So, we look at the top 3 PBMs and, they control 80% plus of the market. Mm-hmm. And, I wonder, why do employers go that route? And it's because that's what's handed to them. The TPA or whoever's doing the plan says, well, these are top 3. They're the best. But they're not. They're the biggest. And so and as Gary Becker says, nobody gets fired for hiring IBM.
Right.
And so you bring that in, right. You expect to be the best. And then once we tear apart a contract and we look at all of these things that are slanted, that's when the employers realize it. So, and that's what we're trying to do is we're telling employers, bring us your contract, bring us your pharmacy spend.
It's always a good place to start.
And let's just show you so you can see what's going on. If you don't want to move to a fiduciary premium, you want to stay with CVS, Caremark, or somebody else, then maybe on your next contract negotiation, you can try to change some things. But if I'm an employer, if you're an employer and you're talking to me and I say, okay, if I'm looking at a PBM, I'm trying to find a PBM. Mm-hmm. What are a couple of questions they should ask that PBM?
Yeah, and excuse me. And usually it's through the broker consultant, right? So you're going to be asking your broker consultant those questions, right? But some of the things that and you pointed out in your contracts, what is their commitment to fiduciary compliance, right? What is the language in and around the definition of a brand or a generic? Something as simple as that. There's a lot of wiggle room in a lot of contracts, which allows you to kind of redefine what a brand is and what a generic is to hit some guaranteed discount that may or may not be real. Are you locked into using the PBM's specialty pharmacy? Are you locked into using the PBM's mail order pharmacy? If the answer is yes, employers should ask, why? Why do I have to use your pharmacy? Right? Why can't I use the pharmacy that is the best price for that one drug? Right? Anything that would indicate a potential conflict of interest should be an area of question.
There's a conflict of interest on every page of this, but
well, I didn't say it'd be a short conversation.
Yeah, but it is fun. Another thing you just mentioned, some of the things of directing into pharmacies and directing to places where they control it, they profit off of it, and it isn't fair. Another thing I saw in the contract was basically, and we talked about this yesterday as well, is dispensing as the doctor writes it. Doctor says you're going to take this high drug, and it may not be the best one, or it may just be the higher price, or it's the doctor that just had that pharmaceutical rep in their office, and this is the one on the top of my head. I'm going to go ahead and sell, because doctors don't know what the cost is to you. They don't know what the drug cost is to the health plan, and so we see that in there. So how do you handle if a doctor says, I want you to take, I don't know, Vyvanse or Humira or whatever, something where there's other alternatives.
Sure.
How do you handle that from that perspective versus just saying, hey, we're going to write the check? Because you're not writing the check, the employer's writing the check.
Right. Right. No, that's a good point. And you're absolutely right. Unfortunately, in the current modern day of technology, doctors do not have access to the cost of medications. They have no clue. So part of what we do when we're approaching a doctor about a prescription that they've written that we know is not cost effective is we'll educate them. There's a good example of a generic drug for diabetes, metformin. The generic version of Glumetza Fortimet is 1,000 milligram extended release, and slight change of formulation, and they were charging $2,000, $3,000 a month for a generic metformin. So we go to the doctor and say, hey, if you would just change the prescription, instead of the 1,000 milligram, write the 500 milligram extended release. The patient would have to take 2 of those instead of 1, same medication, and you can get it for less than $10. Right? The doctors had no clue that they were. Matter of fact, a friend of mine, his wife is a cardiologist, University of Pennsylvania, and he asked her, do you write the 1,000 milligram extended release metformin? And she says, yes, I write it all the time. He said, why? It's $3,000. She had no idea. He says, why do you do it? She said, because on my electronic medical record, it's on the list and I pick it. Right? So doctor education is a big part of it. Also reminding them that, there are all other alternatives out there. And the other thing, we've talked a lot about the employer cost. We often forget about the member. Do you know that in recent studies, on average, individuals are spending 11% of their annual income on premiums and deductibles? 11%. 34% of the average household, 34% of the average household income goes towards food. So now you got 11% plus 34%. Childcare, 13%. Then you got to pay your taxes. What's left? Right? We find that when we engage with an employer and they're saving 50%, the employees are saving 30 to 40% on their spend also. We often forget to talk about that, but that's equally important. It's not a zero-sum game. One wins, one loses. Everybody wins.
Well, I think you hit the nail on the head with that last statement, because in the chapter in the book on that, Life and Death in the Drugstore, I talk about people not being able to afford their medications. And so what do? They ration it.
Yeah.
They half dose it. They cut pills in half. They don't take it at all. We talk about adherence to medications. That's how you stay out of the hospital. That's how you reduce your medical claims, because you're getting people to take care of themselves. And so, that's a big portion of it.
It's huge. Another case example. So we're working with a national organization. They're in the child care realm and child education. And they've saved millions of dollars over the years. All the strategies that we've talked about. And when we first engaged with them, and they're not a high margin business, plus they got hit with COVID, they had to close 50% of their centers. I mean, it was devastating, right? They've saved so much through our pharmacy programs that they're now talking about waiving copays for all diabetic products. Oh. Why? Because they have a substantial diabetic population within their mix. And the number one complaint amongst their members is the cost of diabetes medications. Right. And they would never have had that discussion or conversation a few years ago. They couldn't. Right. So now that their fund is in a lot better place, their costs are way down, they're able to give back. Right. And that's just one example of many.
I love it. So, this all comes back into that partnership. And so, the 3 things that you hit on, we need to find a partner, a PBM partner that is transparent, that takes fiduciary responsibility.
That's clinically oriented.
And managing the risk.
Right.
I love it. Renzo, it's awesome to have you in here and talk about this. It's an area that I love discussing. You've been instrumental in the things we've done for our clients and even my own education in this space. So I appreciate that. For those that are listening to that, maybe employers, how do they get hold of you? What's your website?
Yeah, I would just go USRXcare.com, and our phone number is there. Even better, they should call you.
I agree.
Right?
That's awesome. And it's still out there. If you're an employer and you're looking to make some changes, or at least find out what your plan could look like, what's wrong with your current PBM, we will offer anyone that watches this, a free consultation where we will analyze your current pharmacy claims and we'll look over your contract as well. So I really, encourage you to do that and look at that low hanging fruit and see if you can make some changes to your plan that have real bottom line results with very little noise or interruption to your plan. So Renzo, thanks so much for coming in. I appreciate it. And everyone, thanks for tuning in. And here's a few words from our supporters and sponsors. Thanks. Thanks everyone for tuning in to the Ovation Show. We'd like to give special thanks to our supporters, Craig Shelley Luxury Watches and Fine Jewelry out of Beverly Hills, Success North Dallas, where Bill Wallace has been making connections for over 30 years, and Work Innovators, where they're amplifying the voice of business. And now a special word from our title sponsor.
Employers turn to TBX to provide a modern, seamless, and hassle-free self-enrollment experience for core and voluntary products aimed at educating, not selling to employees. In fact, not only can employers provide a user-friendly, mobile responsive technology solution full of dynamic communications, professional videos, and a data-driven decision support tool, they can do so at no cost to them. That's right, with TBX, there are no setup fees or PEPMs, and there's no need to replace existing technology, as we can easily snap onto any existing HRIS and HCM systems. Plus, the enrollment experience is ready in just 30 to 45 days or less, and data files are properly formatted and delivered to carrier and payroll destinations quickly, securely, and accurately. We look forward to helping you accomplish what others can't: a state-of-the-art technology platform for open enrollment, new hires, and qualified life event processing that's simple to implement and maintain. A partnership that's a perfect fit. That's TBX.